Good evening, ladies and gentlemen. Gavin McHugh is my name, and I'm an orthopaedic surgeon based here in the sports surgery clinic. And I also work in Beaumont and Kappa hospitals as well. I've been invited to talk along this evening about a few problems that I encounter regarding the hip and knee. And hopefully I can basically shed a bit of light on some of these issues, find out simple advice as to what you can do with certain things. And we'll also have a bit of a chat about what's involved with going ahead with things like surgery in terms of joint replacements and the recovery process, and how to know when and in order to go ahead with the problem. So if we start off really with the hip, and again, this is going to be really quite simple in terms of breaking down the problems that we see. The first problem that I would see probably about 10 times a week is an issue called bursitis of the hip, right? So a lot of people think they've got arthritis in their hip and they come to me, but they point out over the side of almost the buttock area. So it's out over, right out on the outside. And the first thing to say is that true hip pain is usually actually right in the groin area. So oftentimes when people have arthritis in the groin, they think they've got a little groin strain initially, and that's often how it presents. But bursitis presents as a pain over the side of the hip. So classically, patients come to me and say, they're having trouble sleeping at night. Whenever they roll over onto, say, their right side, they get a pain out over the outside. Generally they've no problems with things like moving the hip, but things like going up and down stairs that involves quite a bit of hip movement can recreate that pain over the outside, shall we say, of the thigh area as well. Sometimes it radiates down to the side of the leg a little bit as well. But quite often it's just a localized pain. And you know it straight away clinically, because when you press over the outside of the thigh area, patients generally hop and go, that's really, really sore. As I say, I see it quite frequently. The vast majority of times it can be settled down with some sort of physiotherapy to help strengthen the glutes, abductors and posterior chain in general. Quite frequently, I'll also inject it as well. And a lot of times GPs will be willing to inject this as well. If not, sports medicine physicians will often inject it as well. So there's a plethora of options there in terms of who to go to and deal with that. Quite often I find it takes a second or even a third injection to really knock it for six. But generally, we'll be able to get that to settle down without an operation as such. And then straight on to the next problem, which is just arthritis in your hip, and how do you know when you're getting arthritis in your hip? And I suppose a good question, because a lot of the time arthritis in the hip creeps up on people really, really slowly and subtly over years and years. It can, as I say, start off with a little bit of an ache right in the groin area. And sometimes it comes on after, say, a couple of miles of walk initially. Sometimes people notice that they're having a little bit more trouble getting their shoes and socks on, things like that. A little bit stiffer getting into and out of a car, things, or going up and down stairs. And it's usually only later in the sort of the process that they'll get a lot of pain at night time, where it's often waking people from sleep. So, as I say, it often comes on quite subtly initially. All right, what to do initially? Not a lot is the answer. Simple analgesia, even just taking paracetamol, can often help. Anti-inflammatories are usually the most effective painkiller for any musculoskeletal issues in general. But obviously, they come with the risks regarding, say, your tummy in terms of potential for ulcers and a small risk of other things like cardiac issues and stuff. So, I mean, that has to be offset, but at the same time, you can't be going around in pain all the time. So what I'll often say to people is that if you know you're going to be going for a long walk, or if you know you're going to be playing a game of tennis or golf or whatever you do, you might just take an anti-inflammatory just before that. And quite often people can get through even a couple of years before moving on to the next level. In terms of physiotherapy for arthritis in your hip, absolutely, in terms of strengthening issues, but I'll often find that people who put a lot of focus into deep stretching to try and improve the movement will actually frequently exacerbate the problem. And I think that's just where basically what you're causing is an actual pinch in the hip itself. So part of the arthritis process involves more bone being formed around the ball itself, and to try and force that movement, as I say, frequently just aggravates things rather than actually improving it. So I tend to say to people to work really within their comfort zone in terms of the range, and not to really push those end movements too much. And often, if you do that, you can get away for a long time. How do you know when it's time to go ahead with something more substantial? Well, really, in terms of arthritis in the hip, the only real option is a hip replacement. Injections for the odd person can give some temporary relief, but in comparison to knee problems, I find it's often quite short-lived. And in general, it's not something that I would recommend a lot. Potentially with very early arthritis, it could buy you some significant relief, but frequently we'll see people present or patients present, and they're often well down that line in terms of the process. So ultimately for me, a lot of the time it comes down to, is it time for a joint replacement or not? And quite frequently people have an old-fashioned view of this, and that you need a joint replacement when you're absolutely, in dire straits where you can't really walk or you can't do anything. And that's really, really not true. So I would summarize it, I suppose it's time for a joint replacement when you've got pain on a daily basis that is significantly interfering with your day-to-day activities. So if you find that, as I say, you play golf or you play tennis or something, and you're saying no frequently to this because you know you're going to end up in pain afterwards, or and pay that price for the rest of the evening or the following day, and you've stopped and done, well, that's when it's time, as far as I'm concerned, to start to strongly consider something more like a joint replacement. And the same thing would be said at night time. If it's something that's waking you up from sleep most nights, then as far as I'm concerned, a joint replacement should be considered. And the average person who has a hip replacement actually finds the recovery process a lot easier than they had anticipated. And now, it's not to say that it is still a significant operation, and it's an operation that comes with risks. Why am I then so happy to recommend it? Well, we know that patients who with moderate symptoms, shall we say, are the group that actually end up benefiting most following a joint replacement. So it's not the most severe group. The most severe group, and I often say to people, it's almost nearly like the ship has already sailed, whereas if you've got moderate symptoms and you're still just about clinging on to being able to do all the activities you want, well, then very easily you can get that back again after the surgery. The recovery process after a hip replacement, in general, most people are back to see me in about 6 weeks, and most are doing very well at that stage, either off crutches completely or just using, say, one walking stick or one crutch, but it varies from person to person. And overall, by 3 months, I would say that the vast majority of people are more or less completely recovered at that stage. But as I say, by 6 weeks, a lot are really well on their way. In terms of what else was going to, sorry, is there anything else in terms of hips? What I'll often get asked about is people who come with both hips, and it's something I've moved more and more towards over the years in terms of replacing both hips at the same time. Now, a few years ago, it sort of came as a real shock to people that this could be done. More and more, I think people are hearing of it, and it's something I'd be a strong advocate for. Especially if both hips are pretty much where one is as bad as the other, or it's quite marginal, then as far as I'm concerned, as long as you're fit for it, it's an absolute no-brainer. You obviously get to recover both at the exact same time, and one doesn't hold back the other at all. In fact, quite the opposite. I find that people who've both done often recover almost quicker than if they had one done. And the first day or so is a little bit slower, because you have to try and sort of find your legs as such in terms of getting up and getting going. And after that, people really, really get going quite surprisingly quickly. And from my point of view, in terms of the risks of surgery, the risks of having both hips replaced at the same time is actually lower than if you had one done followed by one done a few months later. And there's quite a bit of evidence to show this. With knees, the jury's out a little bit more in terms of having both knees replaced at the same time, but with hips, it's quite well recognized now. So again, as from my point of view, it's something that I would frequently do, usually 2-3 times a week, would place both hips at the same sitting. And as I say, it's the whole idea of a hip replacement is often alien to people initially, but as their sort of pain starts to increase, they start to come around to the way of thinking of it. And for one thing that I love to see is a patient coming in going, I'm ready, and they know. So there is no point in me trying to talk someone into an operation that they're not ready for. And the idea has to sink in within them and to realize that it's time. And again, usually there's no surprises in that of the patients in their 60s or 70s. But not infrequently, we see people in their 30s or 40s who are really, really struggling on a daily basis. For those, it takes quite a while longer for that penny to drop. I'll often say to people that it really doesn't make any difference from my point of view in terms of the surgery and the outcomes. And at the end of the day, the joint is being replaced. So going on and for another couple of years, from my point of view, makes no difference in terms of the what I can do to fix the problem in general. So, but the important thing is that that you're ready for it. And then if I just move on then to the a few issues with regards to the knee. So first of all, just in terms of which we see again all the time, is meniscal tears, or are meniscal tears, sorry, or tears in the cartilage that people will talk about. And quite often patients in their 40s or 50s, they're out walking, they're doing sometimes they're even just getting up from a sitting position, and they feel a relatively sudden onset of pain in the knee, usually associated with mild swelling in the knee. And really quite uncomfortable. And again, it's usually over a localized area, way most commonly just on the inside knuckle of the knee. As I say, the vast majority of times this will settle down with just some painkillers or anti-inflammatories, as we've talked about. So it is something that you can, as we often say, skillfully neglect for a while and see, does it settle down? And if it's not settling down, well, then it's time to start the ball rolling in terms of going to see your GP and potentially getting an MRI scan organized, which is what often happens for patients now, is that they'll arrive. Most patients will come and see me with the MRI scan. That's how things have moved on. Now, it's not absolutely essential, but that's the way most will end up presenting, is with a scan. Again, assuming this problem has been going on for a few weeks, quite often the first thing that I'll do is to just inject the knee. And whereas I said injections in the hip often don't give very lasting relief, injections for tears in the cartilage in the knee will often give a few months of good relief. And this will often just fast forward you 3 months down the track, whereby if we had have done nothing, things would have settled themselves anyway. So not infrequently, one injection gets you right out of a rut and back on track again. And so certainly worthwhile trying. And for me, this has taken over from a lot of what we used to, keyhole surgery that we used to do on these type of tears. And really, whilst it's something that I would still do, the role for keyhole surgery with these type of tears is way, way more limited than it used to be, because we know that in terms of longer term relief, it didn't sort of necessarily fix the problem for patients. But again, if someone's having mechanical symptoms in the knee, and what we mean by that is if that it's actually really, really catching on you or locking, whereby you've a block to fully straightening or bending, then you're potentially going to require a keyhole or arthroscopic surgery, as it's called. Moving up from that, then, and the next thing is then when this process is then continued over a few years, because what happens is that quite frequently people will tear the cartilage. It settles down then for a few years, but because some of the shock absorption ability of the knee has been lost, this then the surfaces then quite slowly over a few years then end up sort of getting eroded away, and that process is arthritis as such. From the arthritis point of view, again, pretty similar to the hip. What goes well, things like injections can work well to give you some temporary relief, and there's a plethora of sort of injection options, from a simple steroid injection to things like hyaluronic acid injections, to PRP, which is platelet-rich plasma injections, which are your own blood that is spun down as such in order to extract the goodies as such from it. And then the last thing is that as patients will sometimes mention are stem cells, which at present is still very expensive and has a very, very limited research base. But the first three injections I mentioned, from my point of view, I don't see an awful lot of difference between any of them, and any can work fairly well in terms of getting you out of a rut. In terms of a more definitive treatment, then again, you're moving up into the replacement territory. And just before that, people will often ask, should I mind the knee? Should I avoid doing things? And I would say the absolute opposite. I would say, no, don't. I would say use and abuse. And there is no evidence whatsoever that minding a joint that has a bit of wear in it increases its longevity as such. And I firmly believe that when people stay active and stay strong in terms of their quads, for example, that they're actually probably more likely to get a longer time period out of it rather than the opposite. So for me, as I say, very rarely should you cut back on activities as long as you're still able to do them. In terms of the replacement options, the one thing that I am a fan on is a partial knee replacement rather than a full knee replacement. And I start off by saying, like, a full knee replacement is a significant day out as such, and in terms of your of what's involved and the recovery process. And in contrast to a hip replacement, I say tell anyone going for a full knee replacement that the recovery is at least 6 months, and it's often certainly 3 or 4 months before you're back on track and starting to go, God, I'm glad I had it done type of thing, which is a considerable sacrifice for patients. Now, again, the other way to look at it is that they are in the recovery process rather than sort of slowly getting worse and deteriorating with time, but it still is a significant recovery process. And so back to the partial knee then. So what exactly is involved with that? With a partial knee, and I hope you can see this here, I'll just show a full knee replacement first of all. I'm going to hold it up here, and I hope I don't look like an idiot, but this is a model of a full knee replacement of what you replace. So this here, the plastic is just the model of the end of the femur and the tibia, but we replace the whole end of the joint, all right? And you can see that what you end up getting on the femur side is quite a large, I'll just struggle to get this off, is quite a large implant there. And this is made of cobalt chrome. It's quite heavy actually, all right? So it's not hard to see that for that to go inside your knee, that is, number one, it's a significant operation, but number two, it's something that's going to feel like a replaced knee as such, rather than the knee that you had 20 years ago. So in saying that, it can be fantastic for fixing the pain. But in terms of how it moves and feels, it's often, as I say to people, it's a replaced knee. It's not your old knee. A partial knee, on the other hand, and again, if I just show you on the model here, you can see that you just replace one knuckle on the side of the knee. And in terms of the size, I can only get one of the pieces off, but it's a much, much smaller little implant. And for me, so who's suitable for that? Well, up to about 50% of knees are actually suitable for partial knees. And it's where your wear is localized to one portion of the knee itself, either on the inside knuckle, the outside knuckle, or more rarely on the front where your kneecap rose off. And the advantages in terms of why we go ahead of it, well, one, it's a smaller operation. It's kind of like a third of a knee replacement in terms of what the implant size that you get put in. And it behaves like that in terms of the risk profile as well. So your risk of things like infection, clots in the form of DVTs or pulmonary emboli, and things like stiffness, heart attacks, strokes, lots and lots of nasty things that thankfully are extremely rare, and are all cut in three with a partial knee. So for that reason alone, I think anything I can do to reduce the risk profile for patients is well worth considering. And as well as that, the recovery process is usually in terms of a few weeks rather than a few months. So it's 6 weeks. Quite often a partial knee is functioning like a full knee at 6 months. And in terms of how the knee feels afterwards, it's much more likely to feel like your old knee rather than a replaced knee. So this is something from my point of view, the patient can get back to a much sort of higher level of activities on average than with a full knee. And there's no reason why you couldn't make it back to a lot of sporting activities, things like tennis and badminton, squash, all these type of things are well within, or indoor soccer, all that within the reach of after a partial knee. It's possible after a full knee replacement as well, but I would say less certain as to how the knee is going to function. So for me, that's the advantages of a partial knee. And in terms of how they function, how they last almost as well as full knees. But, and I use the word almost, well, there's got to be some restriction because you're leaving 2/3 of the knee behind. So there's always going to be a chance that deteriorates with time. But in reality, the risk of that is at about 2% at 10 years. So that 2% risk for me is more than offset by the benefits of the partial knee. In terms of what's involved in the recovery from either, and this goes to hip as well, here in the sports surgery clinic, you're talking usually a 2 to 3 night stay after your surgery. When do you go home after a joint replacement? Well, you go home when your pain is controlled and you're safe and mobile, all right? So as long as you're independently mobile and have minimal discomfort, you can go home. If that's the following day, perfect. If it's 2 or 3 days later, then that's fine as well. And everyone will have their own pace in this regard. Usually partial knees will get going a day or so earlier, and they may go home a day after or 2 days after versus 2 to 3 days for a full knee replacement. And in terms of after that process, again, this goes for hips and knees. You're given your crutches when you're here, and you wean yourself off those over the course of the few weeks. And for some people, that is 6 weeks. For others, the crutches have gone at 2 to 3 weeks, and you can progress this up yourself in terms of increasing your mobility around the house first and foremost, and then as you sort of venture further and further out and about, you can start doing more and more. But for me, it's feeling there's no point in limping and getting off any walking support. You're much better off taking your time and walking with a better gait pattern as such. And as I say, in terms of the recovery in general, hips tend to find it easier. Knees, from a full knee point of view, find it every bit as hard as they were expecting. In fact, even more so. And quite frequently, then, just with the last one, that leads me then to the point of both knees at the same time. Again, it's something I do quite often. I'd have a very low threshold with doing both partial knees at the same time. For both full knees or total knee replacements, it is a significant undertaking for people, but I would describe it as really grabbing the bull by the horns in terms of this is someone who wants to get themselves sorted, get recovered again. And I'll ask everyone who comes back after having both knees replaced, was it easy? And they all say the exact same thing. They go, absolutely not. It was horrendous. It sounds surprising, me saying that. But the second question I ask them is, do they regret having them both done at the same time? And they say, absolutely not, because I wouldn't have come back for the second one. And with that sort of not so pleasant thought, I do say that they do end up coming back, but they end up coming back another couple of years later when they've deteriorated even more. So it's one reason I suppose I've come around more and more to the idea of just fixing the problem as quickly as we can to get people back. And the more or the sooner we get people back fit and active, the the better it is in so many ways for them in terms of their overall health, in terms of the pain relief that they get as well. So, as far as I'm concerned, I mean, if you're really struggling from a quality of life point of view on a daily basis, be it your hip, be it your knee, it's time to get something done about it, to get it fixed, to get things back on track, because there is no sense in going and sliding on down that slope as such in terms of deteriorating further and further. So I hope that's a few issues sort of raised today. I hope people find that in some way interesting. Hopefully I didn't go too fast through any of it there, but really hope you've enjoyed listening, and thanks very much, and all the best. Have a good evening.
Gavin, thanks very much for that. Now we have a lot of questions. We'll try and cover a lot of them. Some of them were grouped together because they're kind of asking the same thing. So one of the things that I've noticed is people are asking who are in their 40s and 50s who are worried about their hip or knee replacement, having a hip and knee replacement at that age, or being told that maybe they're too young yet to have it, even though they're in a lot of pain.
Yeah, thanks for that, Fiona. And so the way I get around that, I mean, is I would say to people, obviously, it's not ideal to go ahead with a joint replacement in your 40s or even 30s or 20s, even if necessary. And believe occasionally that is the case we find ourselves in. But it just really comes down to weighing up the sort of the potential benefits and the relief with what you are potentially setting someone up for in the future, all right? And by that, I mean, is this, if someone is in their early 40s, are they looking at having, a joint replacement revised again in their 60s and maybe then in their late 70s and stuff like that? So, I mean, if you're in your 50s, you've probably a 30% chance roughly that you're going to, on average, that you're going to end up having a revision done at some stage in your lifetime, all right? Okay. If in your 40s, that might rise to maybe about a 50-50 chance of having it done again. If you're in your 30s, you're almost certainly going to end up having something done again. But it just weighs down, or it boils down to sort of weighing that up with the potential benefits and how bad someone is. So someone, again, I go back to things like the night pain. If it is waking you every night from sleep or multiple times, and it's holding you back from the things that you like to do day to day, then potentially then you're shifting towards then having something done about it.
Yeah, thanks, Gavin. And another question, and I suppose someone's asked, will they, after a hip or knee replacement, be able to ride a motorbike? Will they be able to play with their children in the garden? That kind of thing.
Yeah. So again, those type of questions. I would look at a joint replacement as, in general, an opportunity to get back doing things. And the only sort of reservation that I would place on a hip replacement or even a knee replacement to a lesser extent is not going back, for significant road runs. And by that, I mean, it's fine if you're in the gym, sort of doing a kilometer warm up or something on a treadmill. But if you're someone that loves going out for 3 10-mile runs per week, then, a joint, I would say pick up cycling, something like that. Aside from that, I mean, I'm happy for people to go back playing tennis. I'm happy for people to go back playing indoor soccer. I'm happy for them to go riding a motorbike cycle. Absolutely. And playing with the kids. That's the whole point of ways of getting a joint is that you are able to do that, So in general, the answer is yes, rather than no to activities like that. For me, like some surgeons might be slightly putting, again, I have no problem with people going back skiing, for example. I don't see the risk there. I mean, there's always an inherent risk with anything that when you're doing that you could have a fall and injure a joint, whether it's replaced or not.
Yeah. And one person who is a young mother actually having a hip replacement just asked, how long would she be out of action? I suppose that is important if you do have young children.
Yeah, absolutely. And I suppose that it depends on what you define by out of action as such. Yeah. So, I mean, like the process, the rehab starts that day quite often, and you're up taking a few steps the day of the surgery. By the time you're going home, which is 2-3 days later, you're independently mobile, right? Yeah. And I'll often encourage people to get off sort of crutches around the house 1 to 2 weeks. Now, not everyone is able to do that, and for a lot of people, they might still require even 1 crutch at 6 weeks. They might still be using even 2 crutches for 4 or 5 weeks when out and about. But as a guide, it obviously really depends. You're not going to be lifting, big lumps of children around the place and doing a lot of work like that. So you could be talking sort of around about 4 weeks, So people going back to office work type of things, I mean, a couple of weeks is quite possible if you're self-employed, but don't make the mistake of selling yourself short. This is, the most important thing is your own recovery. And, sometimes you have to say, listen, I'm going to be out of action for 6-8 weeks, pending review, and, get it right, because getting it right first time is the most important thing. No employer or family that matter, credits people for sort of getting back to it and then having to go off again because they've overdone it or something, So, yeah.
Okay. Nicola said she's excruciating pain in her left hip buttock on and off for 2 years. She's been to the doctor. It's been told it's sciatica, but it's on the right, on the bend to the outside. It seemed like what you were describing as bursitis in your talk. She's tried anti-inflammatories, but had no effect.
So again, obviously, it's very difficult to sort of answer a question like that there just without saying it. The one quick guide for a person is that it's really sore to press. So over on the outside of the hip area, right where there's that bony prominence, if that's sort of really sore to touch or to lie on, then there is a local issue there. It has to be a sort of a local inflammation, as in a bursitis or tendinitis or something like that. Now, there can be a coexisting problem with the lumbar spine that amplifies it, but there has to be a local problem by definition if it's sore to press. And I'll often say to people, well, listen, let's tease it out. Let's inject that area and see how much relief you get from it, and that'll give you some answers. Okay,
thank you, Gavin. Is it beneficial to take anti-inflammatories periodically following a knee replacement in the first 3 to 6 months?
It's not essential by any means, but you do certainly see some knees that, particularly if people have been quite reliant on anti-inflammatories for a good period of time prior to the surgery, I think they do almost need to wean themselves off them, and they get a little bit of rebound inflammation. So not infrequently you'll get someone who might need to take one every other day for a period of time and so on, but it's just modulated by the swelling in the joint. If it feels good, then absolutely not, right? But if it is a bit inflamed of itself, then potentially yes.
79-year-old is saying he's been told his knee is bone on bone. Would he be a candidate for a partial knee replacement rather than a full?
It really depends on where the bone on bone is. So, I mean, as I said, there's 3 different areas in the knee. If one of them is bone on bone, which it may well be, then yes to a partial. If 2 or 3, then no, it's in likelihood of full knee replacement. But and again, there's no point in having a partial knee if it's not it's not going to fix the problem if it's a different problem. So, but the key to that there is how localized the pain is for the person. So if they point just inside the knee, for me, that's a good indicator that they're going to be suitable for a partial.
Yeah. And some people have asked, is there a difference between how long a partial knee lasts to a full knee?
Yeah, I mean,
they're young.
So yes is the answer to that, but actually quite marginally so. All right. So, and the way I explain that to people is that you're leaving 2/3 of the knee behind. So obviously there's a chance that can deteriorate. All right. And if you look at the UK Joint Registry, the figures for the 10-year survival for a total knee, for an average total knee, is 96%. For a partial knee, which is the Zook is the variety that I use, but it just, I have to get compared with something, it's 94%. So 2% difference for keeping 2/3 of your knee. And for me, I'll often say to people, even if that figure was 10%, I would take it, all right, because the benefits more than outweigh those risks, all right. So marginal, but yes is the answer, all right.
Someone was asked if bad varicose veins are a deterrent for a knee replacement.
It's certainly not ideal. It can tend to bruise and swell a bit more after a knee replacement. Again, that's the exact sort of knee. If you can get away with the partial knee, it's a less of a hit for the person. Believe it or not, it's actually just a very marginal risk factor in terms of clots, all right? In that like a clot, as we talk about it, is to the deep venous system, not varicose veins. So it's only a very, very small risk factor in terms of clots. But other than that, then No, not necessarily, but it depends on how bad they are.
Yeah. A lot of people ask, and we find as well, about how long should they be experiencing pain after a knee replacement?
Well, again,
6 months. Yeah, I know it's
quite a while. So we know that, and again, I'll often just throw out the figure 6 months, that a knee replacement is a job for 6 months down the line. And now you'll see plenty of people at 6 weeks that are doing really well and are delighted, right? But a lot are still, struggling, and they're still having some pain at nighttime at the 6 week mark that's just on the verge of settling down. And you really see them then turn that corner sort of by 3 to 4 months, and as I say, by 6 months doing well on average. But we know from registry and scoring systems that patients continue to improve up until 2 years after a knee replacement. So now after a year, it's going to be marginal, but I've certainly seen a couple of patients who were, grumbling along at sort of like just around the year mark. And by 2 years, they were a lot happier. So it's often a case of, not to necessarily rush in. And it's sometimes, even if you think it's not working, it's not, you sometimes just have to keep the head and just keep going with it, because it can get there,
Yeah. Gavin, thanks so much. We're not going to get to all the questions tonight, but we've answered a lot of them. So, and thanks everyone for joining us tonight. Please press on the tab for future events. We do have one on the shoulder actually coming up in April. We will be sending out an evaluation form tonight. And remember that this will be on the website for you to go back and watch, or if you have anybody that would like to link in. Thank you.